Hi, my name is Garry Kitay. I'm a hand, elbow, and shoulder specialist at the Jacksonville Orthopedic Institute, and I'm here to discuss the topic of rotator cuff tears. I'd like to thank you all for listening. Okay, so let's get right into the topic. Rotator cuff tears and injuries is a very common problem. It's one of the most prevalent musculoskeletal disorders that an orthopedic surgeon will treat. It actually affects over 17 million Americans. To treat this condition successfully, one needs to understand the anatomy, the pathology, and the natural history of the condition. It's a condition that has been in the medical news quite a bit in the last 15 years, mainly because of the advances in arthroscopic treatment. We have more studies understanding this condition, which is helping us in an evidence-based approach in our treatment. So first, the anatomy. As you all know, the rotator cuff is composed of 4 muscles. Starting from the anterior portion, it's the subscapularis, followed by the supraspinatus, then the infraspinatus, and then the teres minor. Each of these insert onto the proximal humerus. The rotator cuff insertion in this old depiction looked like it was a small insertion point into the proximal humerus. In fact, it's quite wide at about 15 millimeters or a centimeter and a half, and it's called the footprint. And the supraspinatus and the infraspinatus each have a relatively wide and long insertion onto the rotator cuff, and when it's torn, the object is to repair it in an anatomic fashion, restoring the footprint. Another thing to know about the anatomy is the vascular system to the rotator cuff, which leaves the rotator cuff vulnerable in a hypovascular state at the supraspinatus insertion. What causes rotator cuff tearing? Well, there's an argument between the loading group and the aging group. For some, rotator cuff disease is just a condition of aging. However, there is a lot of evidence to point to specific loading of the cuff as the cause of pathology. And this is supported by the rotator cuff not all degenerating at the same rate, but being localized more to the deep portion of the supraspinatus, the upper portion of the rotator cuff. There's also evidence to support that cuff tears begin as partial thickness tears and progress to full thickness tears. And there's little evidence to show that the rotator cuff tears, whether partial or full, spontaneously heal. They tend to stay at that condition or worsen. So what leads to these rotator cuff tearings? There does appear to be a propensity to tearing when the subacromial space is diminished in size. So here on this figure, you can see the acromion. Below the acromion is the rotator cuff. The upper portion of the cuff right here is the supraspinatus, where a rotator cuff typically starts. And it has been demonstrated when the acromion is more curved, or a type 3 acromion as opposed to a flat type 1, there tends to be more pathology at the rotator cuff. Also, when the acromion slopes laterally out of the plane of the figure, it tends to abrade the supraspinatus, make it more prone to tearing. Also, where the clavicle articulates with the acromion, there can be osteophytes or bone spurs with the same problem. Calcium deposits in the rotator cuff can also lead to a diminution of the size of subacromial space and make a more static problem, more likely to cause rotator cuff pathology. But there can also be dynamic causes to rotator cuff injuries. For instance, the humeral head can shift within the glenoid or socket and in that way impinge upon the rotator cuff. This can happen if the capsule, for instance, is too tight, causing the head to capture that rotator cuff and continuously impinge it. And this is seen more commonly in overhead throwing athletes and is a common problem in pitching. If one looks at people who overuse their shoulders, such as paraplegics, in fact, they're 10 times higher than an average person to have injury to the rotator cuff. And dynamic causes of impingement can be divided into anterior impingement, with certain motion of the shoulder making more likely to impinge on the anterior portion of the rotator cuff or the subscapularis, and posterior impingement, where it's more likely to impinge on the more superior and posterior portion of the rotator cuff at the supraspinatus and infraspinatus. Well, how common are rotator cuff tears? Well, certainly it is more common as we age. MRI scans done of 96 asymptomatic patients found that over half, over the age of 60, had a rotator cuff tear, and these are individuals without symptoms. Ultrasound, another modality for detecting rotator cuff pathology, on 411 asymptomatic individuals, found tearing, and this is full thickness, complete tearing, in 13% between the age of 50 and 59, and over half of those over the age of 80. Once again, asymptomatic patients. When a patient is known to have a rotator cuff tear, an ultrasound of the contralateral asymptomatic shoulder, once again, about half of those had rotator cuff tearings over the age of 65. Another more recent study showed that in a patient with a symptomatic rotator cuff tear, the asymptomatic shoulder had a 30% chance of a full thickness tear, and the larger it was, the more likely it was to become painful. So clearly, rotator cuff tears is a condition seen as our population ages, and hence is more likely to become a more common condition that we treat. What do patients with rotator cuff tears complain of? They complain that their shoulder hurts. The pain is often at the area of the deltoid and radiating down the arm. Sometimes can even approach the area of the elbow. It tends to be lateral. It tends to be worse with overhead activities. A very common complaint is that it's worse at night. Also, that not only does it painful to overhead activities, but it's weak. And the discomfort can be there for an extended period of time after the activity is completed. A patient might say they were mowing the lawn and felt fine before, but then had pain for the remainder of the day. Well, let's talk about the exam. First, the rotator cuff tear needs to be visualized and inspected. In the female patient, it's important to wear some type of covering garment that permits inspection of the shoulder. I will use a gown and you wear it in a toga type fashion so the involved shoulder can be inspected and the other sleeve can be raised to look at the well shoulder for comparison. When you check range of motion, compare it side to side, and particularly internal rotation is often asymmetric, and you check internal rotation by seeing how far the hand can reach up the back. As part of the exam, we look for specific tests where the rotator cuff can be irritated. And this can happen where the greater tuberosity of the shoulder, where the rotator cuff attaches, contacts the undersurface of the acromion. And if there's damage to the rotator cuff, pain is precipitated. And the impingement sign, in fact, leads to the rotator cuff being impinged between the tuberosity and the acromion, and will often cause pain between about 60 degrees and 140 degrees. Hawkins sign or reinforcement test occurs when you place the arm in this position here in about 9 degrees of abduction and internally rotate, once again trying to strike the rotator cuff between the bony structures that surround it. Once again, if this causes pain, positive test, which could be occur with tearing or just with tendinitis. You check for strength. We know that larger tears lead to weakness, and we want to check the strength of the rotator cuff. So in the supraspinatus stress test, what we do, and we always compare it to the other side, you place the arm in 9 degrees of abduction, about 30 degrees of flexion, and stress, and see, does this side weak? That's a positive test. or if it causes pain. Sometimes it's not weak, but it causes pain. That's in fact more common, and that's also a positive supraspinatus stress test. The infraspinatus stress test, we're testing more the posterior portion of the rotator cuff, and this is where the elbows are at 90 degrees, and you stress them together. And this is a commonly positive test in rotator cuff tearing, particularly in larger rotator cuff tears. The lift-off test is used to test the subscapularis, which is the anterior portion of the rotator cuff, and you ask the patient to take their hand from the small of their back and push away, and then see if there's resistance to it. And if there is not, particularly compared to their well side, if there is weakness, that is often indicative of subscapularis involvement in the rotator cuff condition. Of course, the neck is examined to rule out cervical spine conditions such as radiculopathy, and a complete neurovascular exam is completed. As far as the x-rays, there are 2 more important x-rays, but a total of 4 x-rays are used for a full evaluation of the bony anatomy of the shoulder. The AP view is here, and you can inspect for the glenohumeral joint. You look at the acromion and look at the distance between the greater tuberosity here and the acromion. If it's normal, there is good spacing there. If the rotator cuff, which is in between that space, is torn, sometimes the space will be diminished. And if it's less than 5 millimeters, often there's very significant tearing there. On the outlet or lateral view, also called Y view, you can look at the acromion and see this acromion only has a very mild curve. At some, you'll see a very large spur that extends downward that can impinge into the subacromial space. On Zenka view, the acromioclavicular joint is well visualized, and you look for arthritis there or osteophytes that can impinge downward into the subacromial space. And the axillary view is a very good view to evaluate the glenohumeral joint and look for other sources of pain in the shoulder, such as arthritis. An MRI scan is an excellent test once there is a strong suspicion for significant rotator cuff pathology. It is not the first test ordered, and it is often a test that's ordered when surgical planning is considered. It lets us know about the rotator cuff, not only if it's torn, but the quality of the rotator cuff. And here on the upper 2, this is at a coronal and this is sagittal, we see the rotator cuff stops about this area here, and then there is more fluid outline to the greater tuberosity, where in fact there should be tissue here. And on the lateral view, here the more posterior portion of the infraspinatus is intact, and here's a teres minor, but in this area here the supraspinatus is absent. And here you see after repair and similar cuts, here's the supraspinatus which is restored, here's an anchor in the humeral head, and here in the lateral view once again restored compared to above in the same patient. Ultrasound is a good test. It's an effective test, but one has to be very skilled at completing it, and it's more reliable with full thickness tearing, not as reliable with partial thickness tearing. By the way, an MRI scan, adding gadolinium and contrast can improve the sensitivity, and the sensitivity for full thickness rotator cuff tears in MRI scan is 90%, but can approach a much higher sensitivity, closer to 97% with contrast. So let's get to treatment now. There is not an evidence-based treatment available yet. We can say that for surgery, there are very few absolute indications. When surgery has the strongest recommendation is when somebody has an acute injury, has a traumatic tear, and are now weak, whereas right before their injury, they were able to, for instance, abduct their arm, bring it overhead. Now they are unable. In fact, you would often examine the patient, find significant weakness with supraspinatus stress testing and external rotation stress testing. Often get an MRI scan of a large tear, and these patients waiting will not help them because actually the surgery becomes more difficult. Relative indications for surgery is when the rotator cuff tear is larger because it tends to progress, when there's significant weakness, and when the symptoms have been present for over 6 months or certainly a year and is not improving with conservative treatment. Well, let's talk about non-operative treatment. Most patients trying non-operative treatment will not cause them any harm unless, like we talked about, in the more acute situation where we're losing time to in not repairing a acute tear. But for most patients, it's a safe approach. Physical therapy can be helpful, but it's actually not been shown in a study to be better than just performing a instructed home exercise program. Anti-inflammatory medications have support in the literature, as is activity modification, and these are often performed for 3 to 6 months. What about subacromial injection? First, it's been shown, even in the hands of experienced physicians, to be actually placed in 3/4 of patients. Still, when given at higher doses, it's shown to be effective and probably more effective than anti-inflammatory. It has not been shown in humans, but in an animal model that receiving excessive steroids can lead to tendon and cartilage damage, and hence generally a limited number of these are performed, often at about 3 a year. And I will limit that in my practice in that fashion. There are common things that are used for rotator cuff pathology, such as ultrasound, acupuncture, and shockwave therapy, but these do not have strong support in the literature. When does a rotator cuff tear worsen? Well, these have been followed, and in fact, about half of the rotator cuff tears do progress and enlarge in patients over the age of 60. When you're less than 60, it's less likely. When the tear is already full thickness, and when muscle atrophy is present. These tend to enlarge, and these tend to be not improve as far as their anatomy. When muscle atrophy is present or fatty infiltration of the muscle, this does not improve, and this is a relatively poor prognosticator as far as patient symptoms. Okay, well, let's say the patient doesn't get better with non-operative treatment. What about surgery? Rotator cuff repair, like we said, the goal is to repair and restore the footprint, the rotator cuff, back to its insertion point. And this was first reported back in 1911. And since then, there have been major advances that we're going to talk about. And one of the major advances over the last 25 years has been, and particularly in the last 15 years, has been the use of arthroscopy. And one of the advantages is there's no detachment of the deltoid, which helps with a quicker recovery. There's less dissection of the tissue, and you get the advantage of really being to inspect inside the glenohumeral joint, to be able to look at the humeral head, at the glenoid, at the labrum, at the biceps. Here's a portion of the subscapularis to see if there's any other coincidental pathology. And it has been shown that today, arthroscopic repair is equivalent to open repair with a long-term outcome. So what do you do with the arthroscopy? Well, you look for damage there. You look at the bicep tendon, and here is a stump of the biceps. You remember in the prior slide, there was a normal-looking biceps. Here's a bicep stump. You can look in the subacromial space, and not easy to see, but this is the rotator cuff, and this is a spinal lead that was inserted, and here is calcium deposit. There was a calcification within the rotator cuff. After you assess the entire shoulder, it's time to look at the rotator cuff tear itself. If it's a full thickness tear, these are classified as crescent shaped, which is, of course, the shape of this crescent over here, which is easy to reapproximate right back to its insertion. U-shaped, which would be a condition like that, where it's essentially an extended crescent, where it's too difficult to bring it right back to its insertion point because it's retracted. And there's L-shaped tears, here like this, that in order to reapproximate it first, you need to bring it back, and this is posterior, and this is anterior. Here's the subscapularis. This is a tear of the supraspinatus. The infraspinatus is still intact and needs to be reapproximated first anteriorly, and then after that to the greater tuberosity. So here is another figure. Here's a similar rotator cuff tear. First, with the repair steps, you clean out the subacromial space, do a prosectomy, you release all the adhesions, you prepare the insertion point and clear off the greater tuberosity. You place your sutures, your anchors. First, you repair the soft tissues side to side, and then bring the rotator cuff back to the greater tuberosity, and this would be the completed rotator cuff repair. So once again, we talked about the crescent shape. Those are easy and can be brought right back down to bone. but then you have these larger tears where first you have to repair the rotator cuff side to side before you can bring the rotator cuff back to the greater tuberosity, which you can't see directly in this arthroscopic image. And of course the goal is to repair this without tension in the repair. You can have these massive tears. Here is the greater tuberosity, here's the humeral head, here's the glenoid. This is the labrum. The rotator cuff is back here, retracted all the way behind the glenoid. Here's a little bit of cuff back here, and this is after it's repaired, bringing the soft tissue back over the humeral head with multiple sutures, and then at the end, repairing it back to the tuberosity. Not all tears are repairable, and there are different techniques you can do to try and help with the symptoms, including just debriding the edges of the rotator cuff, releasing the biceps tendon, doing a tuberoplasty or rounding the greater tuberosity, and there are extracellular matrices that can be used to bridge the gap, but as of now it does not have significant clinical support. And here is this patient once again with a stiff tear. Looks like the tissue's all the way here, but when you take a grasper, grab that rotator cuff edge and pull it forward, you see how you can start covering the head. This is after there's been release of the scar tissue, and then we can start putting in our side-to-side sutures. And there's also other techniques for the subscapularis, which is in the front of the shoulder. What about after surgery? You hear about the long recovery, and it is essential. The post-operative recovery is just as important as the surgery itself, and the therapy that's done post-operatively has to match the repair. So if the front of the shoulder, if it's the subscapularis that's repaired, one has to limit external rotation, or it puts the repair at greater risk. If there's a large tear, you want to place the arm in some abduction so that there's less tension on the repair. It's not just a simple sling that's used, but a sling with an abduction pillow. In general, for every rotator cuff tear, you do not want to be contracting the muscle. You don't want to be firing the muscle because that challenges the repair too soon. And this is, by most folks, 6 weeks, and some do it even longer for 8 weeks. Resistance exercise, where you actually stress against resistance, it could be against a hard surface or using what's called therabands. You want to avoid those for about 12 weeks and return to sports and full duty at the earliest is 4 months, and often takes 6 months and sometimes even longer in larger and more difficult repairs. A word on partial rotator cuff tears. This is seen earlier than the full thickness rotator cuff tears, which are seen more commonly over the age of 60. Partial tears are seen in their 50s and 60s, and they can be divided into articular tears here, which is inside the joint, and bursal tears here, which is superior to the joint on the subacromial side. Also, these have not been shown to heal spontaneously. Well, how do we treat these? Of course, these are treated first non-operatively in every patient. First, treat with activity modifications, anti-inflammatories, therapy program for rotator cuff strengthening, and if this fails, surgical approach, generally done arthroscopically, is a reasonable consideration. Here it's difficult to see, but this is the humeral head, this is the rotator cuff, and here's partial tearing of the insertion of the supraspinatus. When it involves less than 50% of the width, and certainly in a lower demand patient, it's just generally treated with debridement. And this is found to be successful in generally about 85% of patients. However, it's important to know that studies have shown that when you check a patient who had a partial rotator cuff debridement, even with removing any spurring off the acromion at the same time, at over 5 years, 1/3 of patients converted from a partial rotator cuff tear to a full thickness rotator cuff tear. Even with these partial tears, progression of the pathology is possible. And that brings us to tendon repair of even partial tearing. Sometimes we'll fix those, particularly when they involve over half the width of the tendon, especially in a younger or higher demand patient. And there's several techniques for this, also with over 85% good and excellent results with repair of partial rotator cuff tears. What about if the rotator cuff tear is irreparable? We mentioned some techniques arthroscopically, but there are sometimes these patients still have difficulties, and there are muscle transfers that can be used. The latissimus dorsi used for superior and posterior tearing of the supraspinatus, the pectoralis major used for subscapularis, and these are not nearly as successful as primary repair. In patients over the age of 70, there is a type of shoulder replacement called a reverse shoulder arthroplasty, and this has shown actually excellent results, flexion improving from 94 to 143 degrees in one study, and a more recent study from 53 to 134 degrees of flexion, although this is a large procedure and the accompanying potential complications are associated with it. Let's talk about results now. What about our non-operative treatment? Does it work? Well, it works in most patients, approaching 90% of patients if you catch them early up to about 3 months of symptom onset. Once it's over 6 months, that success rate falls to closer to 50%. And for those patients that had over 6 months of symptoms, many still had weakness, and on evaluation, many had muscle atrophy. It's once again, healing doesn't take place of the rotator cuff itself, but we hope that the intact cuff surrounding the injured cuff compensates for that injured or torn portion. What about surgery? What kind of results do we get from surgery? Well, as I mentioned, arthroscopic is equivalent to open rotator cuff repair, and we get around 90% good and excellent results. Massive tearing, even the very, very large tear, 85% good and excellent results at 10 years. But it's interesting to note that a third of these on repeat MRI scans are not intact at 3 years, and over half are not intact at 10 years, but these don't necessarily affect patient satisfaction. When you test them, in fact, they're weaker, the ones that are retorn, but patients are often still very satisfied. Subscapularis here is also 90% good and excellent results. Here's another patient, large rotator cuff tear on MRI preoperatively, same patient postoperatively with a restored rotator cuff. Is arthroscopic repair better than open repair? Well, it's difficult to say that. It does appear that there's less stiffness associated with it, there's less pain associated with it, and patients are more comfortable going home. But overall, the results are similar. In acute tears, as I mentioned at the outset, outcome is improved when repaired within 3 weeks. These are the traumatic tears when one is able to move the arm prior to the injury and then afterwards cannot. We will try and repair these sooner rather than later. Does age affect the outcome? In fact, in older patients, they do just as well as younger patients. What about medical problems, cardiac problems, diabetes? This has not been found to adversely affect outcomes. So age and multiple medical problems, of course within reason, do not, should not make the patient concerned that they can still not have a successful result with rotator cuff repair. Well, what is associated with poor outcome? Well, this has been found to involve workers' compensation when there can be secondary gain for not improving. Smokers have been found to have not as good a result. With large and massive tears, although still can have good results, not as good, and of course associated with a higher re-tear rate. When there's also already muscle atrophy or fatty degeneration, these have been shown not to have as successful a intact repair rate when examined by ultrasound and rotator and MRI scan several years later. However, patient satisfaction is still high. What about anti-inflammatories used after rotator cuff repair? In fact, this has been shown in animal models to impaired tendon healing, has not been shown to affect human healing, but there are those that think this may be clinically relevant and avoid anti-inflammatories after rotator cuff repair. What improves tendon healing? As usual, it's good to be young, and younger people tend to have better healing of their rotator cuff. The smaller the tear, the tendon healing is better, and that's why it's a concern to leave the smaller tears alone, because we're concerned that they may grow, and we said they tend to enlarge in patients that are older, and when there's little fatty degeneration. There are some techniques that can be used by the surgeon, such as using a dual row or a single row technique, which I won't get into, but this appears to improve tendon healing, and the above factors may lead to better outcomes. That has not been shown yet that a better tendon healing leads to a better outcome, but it does seem a rational consideration. And I want to thank you very much for listening to this talk. And if you have any questions, my office number is 904-858-6424, and I'd welcome any questions. Thank you and have a wonderful day.